So next up, for our state-of-the-art lecture, we've got Professor Marios Hadjivassiliou. He's a consultant neurologist and the academic director of the Academic Department of Neurosciences in Sheffield Teaching Hospitals. His primary research is in the neurological manifestations of gluten-related disorders. His pioneering research resulted in defining previously unrecognised disease entities such as gluten ataxia, gluten encephalopathy, and gluten neuropathy. He has published extensively on the subject. He is a founding member of the Sheffield Institute of Gluten-Related Disorders, and we're so lucky to have him here today as an expert in this area with landmark publications, and he really is what started the movement towards this research in Sheffield into celiac disease and gluten-related disorders. So we're so lucky to have him here to speak on gluten sensitivity. Thank you so much.
Thank you for the nice introduction and for the invitation. So I deliberately chose a provocative title because I think neurologists are more interested in brain than the gut, but obviously it's nice to hear about the gut-brain axis now, which has become much more popular. So I thought it would be helpful to start by clarifying the definitions as I see them. I think some are not really controversial, but we nowadays talk about gluten-related disorders as a group of diseases triggered by eating gluten, which obviously includes celiac disease that you all know about, dermatitis impetiformis, which is less common, gluten allergy, which is a different immunological pathway, and of course the area of interest, which is the gluten-related neurological disorders. Now, you are familiar with the term non-celiac gluten sensitivity as used in the gastroenterology world. I prefer not to use that term simply because the patients that I look after who have neurological manifestations, they are all positive for serological tests for gluten sensitivity, whereas the so-called non-celiac gluten sensitivity may be patients that simply seem to improve gastrointestinally when they go on the diet, but they may not have serological tests to demonstrate that they are gluten sensitive. So that's the difference. So I tend to use the term gluten sensitivity as an umbrella term for the whole cohort of neurology patients. So some more points to try and remember. Obviously, celiac disease, DH, and neurological cases may coexist or may be present in isolation. Celiac disease is not a prerequisite for extraintestinal manifestations, and the patients with the neurological manifestations who have enteropathy, for me, are indistinguishable from those who have the antibodies and no enteropathy. So as far as I'm concerned, it's not of interest to me whether they have enteropathy or not, because their response to gluten-free diet is the same. So we started this trip more than 25 years ago when we started looking at the prevalence of GLadin antibodies in a group of neurologic patients with problems that we couldn't find an explanation for. And in that study, which was published in The Lancet, we showed that the frequency of the anti-GLadin antibodies amongst these patients with neurological dysfunction of unknown cause was very high, 57%, when compared to 12% in the healthy population. And when we did biopsies, we showed that the presence of celiac disease was again very high, 16% versus 1%. There's one other important issue about this study, which is, of course, that 72% of the neurologic cases with positive GLadin antibodies didn't have enteropathy. So, and yet they all subsequently responded to the gluten-free diet. So, if you like, it was the first time to introduce the concept of gluten-related neurological dysfunction without enteropathy. And as you know, it took decades for that to become accepted in the gastrointestinal world. So this is where we are currently. It's another landmark because I updated this only yesterday, and we reached the 1,500 number of patients seen in the Sheffield Gluten Sensitivity Neurology Clinic. So these are all positive for anti-GLadin and more laterally TG6 antibodies. And you will see that there are three primary manifestations: gluten ataxia, neuropathy, and encephalopathy. One thing to point out is that the presence of enteropathy in these three groups is slightly different, which is interesting in the sense that only a third of those with neuropathy would have enteropathy, whereas those with encephalopathy, and I'll explain what we mean by that, is 70%, much higher. There are a few other manifestations at the bottom of that slide which are less common and I won't cover in this talk. So how do we diagnose these cases? Well, you'll be familiar, of course, with the endomysium and transglutaminase 2 antibodies, which are available in most centers in the UK. But as I've shown you, you will only pick up about a third to half the patients who present with neurological problems because the majority of patients don't have celiac disease. So we've been using native anti-gluten antibodies for 25 years plus, and we feel that those are much more sensitive to the whole spectrum of manifestations, and unfortunately they are not readily available in the UK. More laterally, we've been using also TG6 antibodies, and I'll tell you a small update about our experience with that. There's one other problem, which is that the level of the cutoff for anti-gluten antibodies in the commercial assay that we use had to be modified for the neurology cases because the threshold for positivity is set based on the presence of celiac disease. And a lot of these patients who don't have celiac disease may have levels of gluten which are much lower than the cutoff for celiac disease. And yet these patients, in this paper, we showed that they equally benefit from the gluten-free diet. So we've got to start with a major diagnostic problem because most immunology labs in the UK don't offer native gluten antibodies and TG6 is not available. Some doctors just simply request celiac screen, whatever that means. Some don't appreciate the significance of the presence of, say, gluten antibodies in the absence of enteropathy. And unfortunately, there's still some of my colleagues in neurology who don't believe in the existence of gluten-related neurological dysfunction, as if some sort of religion. This is one of the commonest pitfalls in the diagnosis of gluten ataxia. This is an extract from a letter, a referral letter from the GP asking me to see a patient with established ataxia. You will see the second sentence that they've done the tissue transglutaminase. They obviously thought about the possibility of celiac disease, but they haven't found a cause. So the patient comes and he has the blood test done in our lab, and you can see that EMA at the top is negative, transglutaminase 2 antibody at the bottom is negative, but the glutins are both positive. And therefore, this patient gets diagnosed with gluten ataxia, they go on a gluten-free diet, and they improve. So obviously, if you don't have access to gluten antibodies, then you're not going to be able to diagnose. The second commonest pitfall is that a patient who is known to have celiac disease who gets referred because they are developing ataxia. So you'll see that this individual had a diagnosis of celiac disease done in 1999. The GP tells me that the patient hasn't been very good with their diet, but now he's much better and the transglutaminase 2 antibody is now normalized, but he presents with a range of neurological symptoms which the GP has diagnosed as gluten ataxia. So we have some very sharp GPs in Sheffield. And he was absolutely right, of course. But again, if you look at the serological profile of this patient, you see that, yes, they are negative for EMA and transglutaminase 2, but they are positive for gluten antibodies. So still some gluten is getting through and is sufficient to cause a neurological problem. And of course, what do? I send them to our experienced, friendly dietitians. And what do? They give the patient further advice, and then you can see how you can then achieve complete normalization of the anti-gluten antibodies over time. So gluten ataxia, a bit more about what we mean with these. So it's a condition that affects your balance center, which is the cerebellum. So it impairs your gait balance, decreases your coordination, causes clumsiness, slurring of speech, sometimes swallowing difficulties and jumpy vision. They get broad-based gait and fall, and eventually, if it's not treated, then leads to wheelchair dependency. So if we can show the first video clip, please.
Baby in passport.
Okay, and next I'd like you to say British Constitution.
British Constitution.
Now go back and forth. Back and forth. That's it. Oh dear.
Cracking nose.
You're-
Mad migraines.
Okay,
I
that's
feel
fantastic.
really
This.
to build up a fluid in there.
Yeah.
Back and
So we're
forth.
doing this.
Like
see if
that.
we can
Like that.
and
Yeah.
we can find out what's
Yeah,
causing
and
it.
on the other side.
And at the same time, I'm going to read your pressure. If it is high, slowly. You're not frightening needles, are you? So what I'm feeling for.
Baby.
So this is the end result of somebody with severe cerebellar ataxia, and you can see how disabled they are. And of course, once you reach that stage, it's difficult to achieve any significant improvement. What you're going to achieve is stabilization. And this is an MRI scan of a patient with gluten ataxia. On the left-hand side, you can see the cerebellum at the back of the brain, which looks normal size. And then on the scan next to it, you see it's only about 18 months later, which is the time that the patient was diagnosed with gluten ataxia. But if you look at the back of the brain again, the cerebellum, you can already see significant atrophy. Once you have atrophy, cellular loss there, you're not going to be able to make a huge impact. And that's something that is obviously is important to tell the patient, because they may not notice any improvement, but they might notice stabilization. So how common is it? So the big white circle there, part of the circle there is the genetic ataxias. And then number 2, the black thing, accounts for all the gluten ataxia cases. So it's probably the second commonest cause of ataxia in the UK. I just want to briefly explain to you this methodology of MR spectroscopy, simply because it's a tool that we use and is proven extremely helpful. So in essence, you place a voxel of interest in the bit of the brain using some software on the MRI, and you get these spectra, these peaks that you can see there. And if you look at the top one, on the right-hand side, that peak accounts for something called N-acetyl aspartate. That reflects how well your cells are functioning. So the higher that is, the better. The second peak to the left is creatine, which doesn't change in health and disease. So if you take a ratio of the NAA to creatine, it gives you a numerical value of how well the balance center is functioning. And that value should be well above 1. And you see on the top that if you take that ratio, it's going to be well below 1. But at the bottom is a spectroscopy done a year after the patient went onto a gluten-free diet, and you can see that the NAA is improving, is going up. And what that tells us is that not all is lost. There's still cerebellar reserve, there's still potential for recovery. And we do this spectroscopy on all of our patients with ataxia, and it's a very useful monitoring tool. So this tells you about the overall effect of gluten-free diet on the spectroscopy in patients with gluten ataxia. So the dark line tells you those who are, represents those patients who are on a strict gluten-free diet with complete elimination of the antibodies. And you can see that the spectroscopy improves. The one that goes dramatically downwards are those patients who did not go on the gluten-free diet, so it gets worse. And then the intermediate one, which is going down slowly, are those patients who are on the diet but are not very strict. So, and the next slide includes just the patients who have gluten ataxia and no enteropathy. The previous one was those with enteropathy. So you can see that there's no difference, basically. You have the same effect whether you have enteropathy or not. Moving on to gluten neuropathy. So this is loss of sensation, tingling, numbness, pain, usually affecting feet and hands, with neurophysiological evidence of peripheral, large, and small fiber involvement, and obviously in the presence of serological evidence of sensitivity to gluten. It accounts for a large number of axonal neuropathies, about a quarter. And if you actually do these tests in a cohort of patients with established celiac disease, you might find that it's very prevalent. This is a study from Finland. And then the big epidemiological studies from Sweden have shown that there is a significant association between neuropathy and celiac disease. We showed that these patients benefit from a gluten-free diet, and then you can demonstrate that the neuropathy improves, and you also, and is irrespective again of the presence or not of an enteropathy. One other important aspect about the neuropathy is the presence of pain. As you can imagine, peripheral neuropathy can be associated with pain, up to 55% of cases. And of course, pain is associated with a poor mental health status. And in this study, we showed that strict gluten-free diet with elimination of all antibodies was associated with significant reduction of the odds for neuropathic pain. So the pain also improves as well as the neuropathy. And finally, gluten encephalopathy. So this is a constellation of symptoms primarily characterized by presence of headache, sometimes mimics migraine, often associated with cognitive deficits, which patients sometimes describe as foggy brain, slow mentation. Sometimes the scan can be abnormal with white matter changes. And unfortunately, these changes don't revert to normality. But if you go on the diet, they will stay static. They will not get any worse. And this is what the scan looks like. So those patches of white matter changes close to the ventricles, which are the very, very white structures in the middle. And what you can see in this case is a patient with gluten encephalopathy 2 years apart without going on the diet. And you can see that these patches of white matter changes are increasing. And this is an end-stage result, so that now we've got a confluent white matter change, and unfortunately this patient is fully demented at this stage. And the issue about the impact of these changes in your brain is an interesting one, because again, going back to the Swedish studies, they looked at the risk of dementia in patients with celiac disease, and they showed that they didn't have an increased risk of dementia overall, and in particular when you look at things like Alzheimer's. But when they did a subgroup analysis, they showed that there may be an increased risk of vascular dementia. And vascular dementia looks exactly like those scans that I've shown you. And we've got an ongoing study now looking at whether healthy individuals who are positive for these antibodies may already have some increased risk of developing dementia. So why do sometimes patients say that their response hasn't been very good? By far the commonest is the problem that you have also in gastroenterology, which is poor adherence to the gluten-free diet. And that's when your input as dietitians is so paramount, really, in terms of helping us with that. You sometimes need to review the diagnosis. You may be dealing with a genetic ataxia who happen to be gluten positive as well. And if it's not behaving the way you expect it to behave, think again, go back, look, and see if you find an alternative cause. Refractory celiac disease in this context tends to be very rare, and the phenotype neurologically is slightly different. And for those patients who are really very, very strict on the gluten-free diet with the elimination of antibodies, and yet they seem to be still getting worse, we sometimes use immunosuppression, but that's rare. So a little bit about the transglutaminases. As you know, there are enzymes involved in tissue repair. They break down gluten into small peptides. These peptides initiate an immune response if you are gluten sensitive, and that's what causes the damage. And in 1997, TG2 was found to be the autoantigen in celiac disease, and then 2002, TG3 was found to be the autoantigen in dermatitis herpetiformis. So in 2002, there was the International Celiac Disease Symposium in Paris, and Daniel Eschliman, who is a transglutaminase expert that works in Cardiff, presented data on a new transglutaminase called TG6, which was brain expressed. And this is a picture of the developing rat brain showing the black areas, which is the transglutaminase 6. So we got together and worked on these. And 6 years later, we were able to show that the patients with gluten ataxia had autoantibodies which recognize a novel transglutaminase, and that was TG6. So it looks as if, similarly to what you see in celiac dermatitis herpetiformis, is the same thing that you see in neurological manifestations. Now, most of that work was done in the lab, in Daniel's lab, and then transglutaminase commercially available TG6 assay became available to our immunology department 2 years ago exactly. So we started using it in a big scale. So what I can tell you is that if you use the definition of gluten ataxia based on the presence of gladin antibodies, and then you look at the prevalence of TG6, then 96% of these patients have TG6 antibodies. So a very good match between gladin antibodies and TG6 antibodies. If you look at those with celiac disease, about half have TG6 antibodies. And in the healthy populations, about 4%. What I think is very important is, of course, that 74% of patients who we still haven't found a cause for their ataxia are positive for TG6. And therefore, TG6 alone may be an additional marker for these cases that may benefit from a gluten-free diet. One other question is, how common is neurological involvement in the classic celiac disease of the kind of patients that come to you that have seen the gastroenterology? So this was a study we did almost 10 years ago now, funded by Celiac UK and Bartan Education Trust. So we recruited 100 newly diagnosed patients with celiac disease from Dave Sanders' clinic, and they underwent an examination and an assessment neurologically. So if you ask your patients about these neurological symptoms, you will be surprised how common they are. So 42% said that they had frequent headaches, 24% said that their balance wasn't very good, and 12% had sensory symptoms. More worrying was the fact that when you examined them, about a third had evidence of gait instability. Some even had nystagmus, which is a manifestation of cerebellar dysfunction, and 5% has sensory signs. So if you put the signs and the symptoms together, then 67% had neurological symptoms at the time of being diagnosed with celiac disease. Even more worrying is when we scanned them, 46% had abnormal mass spectroscopy of the cerebellum. So the process of CNS damage has already started, and 19% had these white matter changes, which you only see in about 3% the healthy controls. In terms of the TG6 antibodies, we divided them into those who had positive TG6 and those who didn't. And we were able to show that those who had the TG6 antibodies were more likely to have a gray matter loss of the brain, in particular cerebellum and some other areas, as compared to those who were TG6 negative. In other words, TG6 tells you that you are perhaps more likely to suffer from CNS involvement. So this clip shows you a patient of this cohort, celiac disease.
I want you to put your feet together.
So I'm asking the patient to stand with their feet together. And this is something you might want to do in your clinics. It's very quick. Okay. So you measure the gait, ataxia, if you like.
Okay.
And you can see that the patient is struggling.
And then I want you to try and walk towards me, but heel to toe.
Heel to toe, okay.
Yeah? One foot in front of the other.
And in case
I want you to put
in case you are not convinced, can we have this clip, please?
So can I ask you to stand on each leg in turns first?
So this is myself instructing myself to stand on each leg in turns, just to show you that my balance is okay.
Very good.
And I was much older than the patient I showed you before. So you should be able to do that without any difficulty. Okay, so we then decided that we'll do a follow-up study of these 100 patients, and we were able to re-examine and rescan 30 of the original 100 patients 7 years after the baseline assessments. We were aiming for 100, but then the pandemic came along, and that's why we were interrupted there. However, we thought that 30 is a reasonable number, and when we look at the differences at baseline between the total 100 and the 30, there were no differences really. Now, the prevalence of headaches had dropped from 47 to 20%, so patients said that the headaches are much better. Patients with coordination problems at baseline reported improvement. However, 7 patients reported new onset of coordination difficulties, which was a little bit unexpected. But when we look at the serology, all 7 have positive serology at follow-up. And interestingly, in total, 50% had positive serology at follow-up, as you might expect. But if you use Gladin and TG6 antibodies alone, you would have picked all of those 50%. So you didn't have to use endomysium and transglutaminase for that group. But some of them were positive for that as well. Now, when we compare the baseline scans to the follow-up scans, the imaging showed a greater rate of cerebellar gray matter atrophy in the antibody-positive group versus the antibody-negative group. Patients with classic celiac disease who do not adhere to a strict gluten-free diet are serologically positive, therefore are at risk of developing ataxia. And that's why it's so important for these patients to be monitored and use serological testing to be able to advise them. So to conclude, gluten sensitivity can present just with neurological disorders, commonest being ataxia, neuropathy, or encephalopathy, or a mixture of those 3. Diagnosis relies on the appropriate serological testing. Patients with classic celiac disease often have neurological problems at the time of diagnosis, but as they are more likely to get diagnosed and treated early, they are protected from developing permanent neurological deficits. Because even those patients who were positive 7 years down the line, the level of positivity was much, much lower. And the degree of ataxia, as you saw, was not at all comparable with the first patient I showed you that came to me already with a severe ataxia. So patients presenting solely with neurological manifestations are often diagnosed late, and we've got that data. It takes about 10 years for these patients to come to our attention. And by that stage, they are like the first patient I showed you that have permanent disability. Achieving serological elimination of all the antibodies is essential for full neurological recovery and stabilization. And we've got data to show that these antibodies cross-react with brain tissue. And finally, there is an urgent need for improving awareness of the neurological manifestations, because if you diagnose them early and treat them early, then obviously you can imagine that the outcome will be much better. So I just wanted to thank all my colleagues at the Sheffield Institute of Gluten-Related Disorders, and particularly my good friend Dave, because it's a joy to work together, both professionally and also having fun. Thank you very much.
Thank you. I think it's been quite a privilege listening to your talk today. You know, I don't often get to hear people who are sort of really at the top of their expertise, essentially. And there's some really interesting questions that have come through. So the first one is there a chance gluten ataxia is being confused with dementia and Parkinson's disease?
No, it's a very distinct entity. So ataxia just coordination problems. Dementia is usually people don't have a movement disorder as such. And Parkinson's, again, the signs are completely different.
Yeah. Okay. And there's another question. I think one thought that I had was that in clinic as dietitians, we don't normally look at patients' gait and movement. That's not something that we would normally do. And one of the questions is asked, as a dietitian or a GP, how do you spot someone with this issue in a timely way? Is there an age of onset, a symptom profile, any primary care tests?
So the mean age of the kind of patients that we see, as you can imagine, because we're neurologists, that will come with a neurological problem is about 53. But by that time it's too late. So the age that you really need to concentrate is obviously at the time that they develop a neurological problem. And the kind of patients that I advise GPs to look for would be patients who have intractable headaches, where you tried your conventional treatment of migraine, for example, and it's not working, and they keep coming back and so forth. That would be one group. Obviously, anybody who complains of balance problems. And again, you can imagine that the patient comes to a gastroenterology clinic, they're not going to start talking about their headaches and their balance. But I guess you as dietitians might be worth asking about those three things: a headache, sensory symptoms, balance problems, and you'll be surprised how common they are.
Yeah. Okay, thank you very much.
Have we got, I think we've probably got to
sorry,
just
yes.
a question from the
Is that
room.
right?
Yeah.
Yeah, so I guess my question is, with these disorders, which aren't celiac disease, how strict do you think the diet should be? Is it more a bit with symptoms, and has it got a long-term therapeutic effect where you would say everyone needs to avoid cross-contamination to, like with celiac disease, for example?
Well, I guess Nick might be the person to answer that question, but I think we both agree that we just need to see the complete elimination of the antibodies. It's surprisingly how if you have a patient and they say they get worse and you do a scan and it's worse, and you look at the blood test and the gladins would be positive, and it's such a good correlation, whereas ones that goes below normal, they will be the ones who do fine. Nick, do you agree with that?
Yeah, it was a great question by Christian. I think in my experience, it's certainly so far clinically, the diet is applied in the same way you would do with a patient with celiac disease seems to be appropriate. So that level of restriction. I think there are one or two patients, understandably, with the symptoms that you get, want to be very, very cautious. And it's about having that discussion with the individual about the benefits versus the social limitations as well. So we want to marry that up. Obviously, we don't want people continuing to have neurological symptoms. But as far as we know, and what I do clinically in practice at the moment is imply it in the same way I would do for a patient with celiac disease.
Thank you.
That's great. All right, we'll take another question, but I think then we'll have to break for lunch.
So Marios, my question is, do we know why some individuals with gluten-related disorders, some have, let's say, celiac disease, intestinal enteropathy, others have neurological manifestations, whereas others have dermatitis herpetiformis? Now, I know you said there's difference in TTGs, but why are they all having different clinical presentations? Is there something else going on, like genetics?
Very good question. What I can tell you is that in the case of dermatitis herpetiformis and the neurological manifestations, the population age is much older. And when we looked at TG6 in various populations, it's clear that the immunological response against TG6 seems to develop later on. So whether it's something to do with so-called epitope spreading, so you start with an immunological response which is primarily against TG2, but the two transglutaminases are 65% homologous, and then suddenly your immune system is beginning to spread into other areas. And a good example that maybe supposes this theory is the story in Finland about dermatitis herpetiformis. So since they've been so good at screening patients for celiac disease, dermatitis herpetiformis kind of disappeared because it was a disease that presented much later. Right. So I think that's probably, I suspect that's not the only thing, but I think that's certainly a factor.
Thank you.